The fluid-solid regime switch in chronic disease, brain aging, and recovery, number 1487, VPT Sharp 048, December 31, 2025. Gerald C. EclaireMD Foundation. Category: Research Methodology and Systems Medicine. Preface: This paper was written to clarify a simple but often overlooked truth. Most chronic diseases do not fail suddenly. They evolve, they flow, they accumulate damage quietly over many years before a visible collapse occurs. Very few patients with metabolic disorders die directly from obesity, diabetes, hypertension, or dyslipidemia. These conditions are rarely the immediate cause of death. Instead, they act as long-term upstream processes that continuously stress the body. The actual causes of death or severe disability are downstream structural failures, such as heart attacks, kidney failure, stroke, dementia, certain cancers, or permanent conditions like neuropathy-related amputation and retinopathy-related blindness. The four metabolic disorder processes, obesity, diabetes, hypertension, and dyslipidemia, operate primarily in the fluid regime. They are dominated by continuous flow behavior, gradual accumulation of damage, and strong time dependence. In their early and middle stages, these conditions remain adjustable and responsive to intervention. Lifestyle changes, improved metabolic control, and sustained behavioral correction can still alter trajectories and reduce accumulated stress. In contrast, mortality diseases and severe disabilities belong to the solid regime. They represent completed or near completed structural failure. In this regime, tissue is lost, vessels are clogged, blocked, or ruptured, neurons are destroyed, and organs are permanently damaged. Recovery becomes constrained by physical structure rather than metabolic control alone, and management replaces true reversal. This distinction explains why metabolic disorders should not be viewed as isolated diagnoses, but as long-term fluid processes that drive the system toward a fluid-solid regime switch. Once that switch is crossed, outcomes change fundamentally. Understanding this transition is essential for meaningful prevention, realistic recovery expectations, and honest interpretation of chronic disease progression. Modern medicine is excellent at recognizing end-stage failures. It is far less effective at explaining how a living system gradually moves from adaptation to irreversible damage. My own medical history, combined with long-term self-observation and engineering-based modeling, forced me to confront this gap directly. Over many years of studying metabolic disease, stroke, cognitive aging, and recovery, I found that a single physical concept repeatedly explained what clinicians describe separately as progression, degeneration, and failure. That concept is a regime switch, from a fluid-like state to a solid-like state. This paper explains that switch, why it matters, and how the same mathematical engine, including the model, equations, algorithms, and calculations, can describe both phases of disease: the fluid state of disease development and progression, and the solid state of disease, manifestation and structural collapse of organs. Introduction. Traditional medicine classifies disease by organ, diagnosis, or symptom. Diabetes, internal medicine, is treated separately from stroke, neuroscience, kidney failure, nephrology, and heart attack. Cardiology, cognitive decline, neurology or geriatrics, is separated from vascular disease. Cardiology or neuroscience. Recovery is often left to therapies or patients themselves, and is discussed without sufficient reference to accumulated structural damage. From a systems and physics perspective, this separation is artificial. The human body behaves as an integrated system, which is also coupled fluid-solid physics system. Blood, glucose, oxygen, and neural signals flow continuously. Vessels, organs, and neural networks provide structure and constraint. Disease emerges from the interaction between flow and structure over time. In engineering, systems that initially deform smoothly under stress, but later fail permanently, are studied using viscoplastic theory. This framework naturally divides behavior into two regimes: a fluid-dominated regime, where deformation is adjustable and reversible, and a solid-dominated regime, where damage is locked in and recovery is constrained. In my biomedical research, I apply this same logic to the human body, which contains many interconnected organs and systems. The human body has about from 70 to 80 major organs organized into 11 major organ systems, which together contain trillions of cells and dozens of tissue types. Although these are not classified as organs, I like to explain it this way so readers can see how complex the human body really is. I further classify diseases types, disease development stages, and disease recovery potential, according to whether the system is still operating primarily in a fluid regime, or has transitioned into a solid regime. The boundary between them is what I call the fluid-solid regime switch. The fluid-solid regime switch. In my medical research, I divide chronic disease, progression and recovery into two fundamental physical regimes: the fluid regime and the solid regime. This distinction is not symbolic. It reflects how biological systems respond to stress, time, and accumulated energy. The fluid stage represents a phase where function dominates over structure. Tissues are alive, responsive, and capable of adaptation. Blood pressure fluctuates, glucose rises and falls. Neural circuits strengthen or weaken with use. These behaviors resemble flowing systems that can change shape without breaking. During the fluid stage, disease progression is driven mainly by strain rates and stress-strain energy accumulation. Stress intensity matters. Duration matters. Energy can build gradually or rapidly. Importantly, reversal remains possible because the system has not yet crossed a structural breaking boundary. When stress is reduced early enough, trajectories can bend back. Glucose control can improve. Blood pressure can stabilize. Sleep can normalize. Cognitive performance can recover through repetition and training. These improvements occur because the system remains elastic and deformable. The solid stage begins when accumulated stress exceeds adaptive capacity or elastic limit. At this point, structural damage occurs. Cells die, tissue scars, vessels stiffen or rupture, neurons are lost. Once this happens, the system behaves less like a flowing medium and more like a permanently deformed structure, either partially or totally. In the solid stage, recovery becomes constrained by physical limits. Scar tissue does not transmit signals normally. Calcified vessels cannot expand adequately. Dead neurons do not regenerate easily. Management replaces reversal, and the goal shifts to preventing further collapse and preserving what remains. Patients begin to assess their remaining functional capacity and quietly count the time they have left. The fluid-solid regime switch is the boundary region between these two behaviors. It is not a single moment. It is a transition zone where reversible deformation, elastic zone, becomes irreversible damage, plastic zone. Clinically, this switch often appears as stroke, heart attack, kidney failure, or irreversible cognitive decline of dementia. By the time these events are visible, the switch has already occurred. Classification of diseases by dominant regime. Using this framework, diseases can be classified not only by name, but by dominant physical behavior. Fluid-dominated diseases and stages include early and mid-stage metabolic disorders, such as type 2 diabetes, before organ damage, hypertension before vascular, stiffening, early cognitive slowing, sleep-related dysfunction, and early insulin resistance. These conditions are characterized by functional impairment, without fixed structural loss. Intervention here can still reverse trajectories or mortality diseases. Mixed regime diseases include conditions approaching failure thresholds, long-standing diabetes with early neuropathy, chronic hypertension, with increasing pulse pressure, progressive small vessel brain ischemia, and pre-stroke vascular fragility fall into this category. Both flow disturbance and structural weakening coexist. Timing becomes critical. Solid-dominated diseases include stroke, myocardial infarction, heart muscle tissue death caused by a sudden loss of blood supply, advanced kidney disease, cirrhosis. Healthy liver tissue is gradually replaced by scar tissue, which hardens the liver, and advanced dementia. These conditions reflect completed regime switches. Structural failure has occurred, and recovery is partial and constrained. This classification explains why the same diagnosis can behave very differently in different people. It is not only what disease you have, but which regime you are still operating in. A common algorithm and computer software used for both regimes. Although I describe fluid and solid stages separately, I do not use separate mathematical models for them. In my viscoplastic medicine theory, VMT, calculations, I use the same equations, the same algorithms, and the same computer AI software, installed on my iPhone, for both regimes. This is deliberate. Viscoplastic theory was created to describe systems that flow, accumulate damage, and eventually fail. Biological systems behave the same way. The mathematics and physics do not change. The interpretation does. In the fluid regime, the model emphasizes continuous change. Stress and strain evolve smoothly, and energy accumulates over time. The focus is on trajectories, slopes, and turning points, which are especially relevant for understanding prevention and early recovery. Results from this fluid phase can be illustrated using VMT strain, stress diagrams over time and cumulative VMT energy curves over time. In the solid regime, the same calculations place greater emphasis on failure-related behavior. Rupture, collapse, and irreversible deformation become central to interpretation. The focus shifts from how the system flows to understanding the factors associated with structural breakdown. Results from this solid phase can be illustrated by VMT energy contribution ratios, which reflect the relative influence of individual input stressors on the final disease strain. These VMT energy percentages help indicate which stressors played a larger role in the disease outcome. This perspective explains why different visualizations are useful for different purposes. Strain stress area diagrams and cumulative VMT. Energy curves are particularly suited to describing the fluid phase, showing how energy builds over time and how prolonged stress gradually moves the system toward failure. In contrast, stressor-energy contribution ratios are more informative. At later stages, when failure has occurred, these ratios help clarify which stressors were most strongly associated with crossing the system's limits. They describe contribution at collapse, rather than the dynamic motion during earlier progression. Conclusion: there is one mathematical engine underneath disease progression, recovery, and failure. The distinction between fluid and solid regimes is not a change in equations, but a change in physical behavior and interpretation. The fluid regime explains why early intervention works. The solid regime explains why late intervention is limited. The regime switch explains why sudden, catastrophic events often appear without warning. Understanding this switch is essential. It shifts medicine away from snapshot diagnosis and toward trajectory awareness. It clarifies why timing matters more than intensity. Most importantly, it shows that prevention is not about avoiding disease labels, but about staying on the fluid side of the boundary for as long as possible. This perspective does not replace clinical medicine. It complements it by restoring physical causality to chronic disease and recovery, and by reminding us that once structure fails, no amount of late effort can fully reverse what time and accumulated stress have already solidified. Disclaimer: I write this article not for fame, but to share what I have learned so others can understand health, prevent disease, and live better lives. This content is provided for educational reference only, and does not constitute medical advice. No doctor-patient relationship is created. You may share this article freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights belong to the author. Gerald C.